Well, thanks for everybody's patience. It's this time of the year in the legislature where things get a little crazy, so these conference committees pop up, but we'll catch up. Today, I will call the meeting to order and do a roll call. So, Mike Brower,
Here.
Sarah Kaler,
Present.
Sandra,
Here.
Gary,
Here.
Jason,
Here.
Mike Kege, Ken Gregoire,
Here.
Monica Murnham,
Here.
Keith. All right, we've got a quorum, and we will move along here. Do still plan to be done by 11:30, and we will, as a board, decide if we might do an interim meeting, depending upon where we're at with the assessment review. So again, thanks for your patience this morning. Thanks for staff making a quick turnaround and getting things set up. So our first item of business will be approval of the board meetings from our March meeting. So we'll look for a motion for passing those minutes.
Sarah Kaler will motion.
Motion, do I have a second?
Second.
Monica Murnian. Sorry, whoever you want there.
Sarah motions and Monica seconds. Any further discussion? All in favor? Aye.
Aye.
Those opposed, same sign. Thank you. And from there, we'll go to Chris. Any updates from the Attorney General's office?
Mr. Chair, just a couple updates for us. I believe since last time, I don't remember the exact timing, but I believe we've got the Kroger settlement final and ordered by the court. So we do anticipate funding from that flowing in soon. I believe we talked about it last time, but I just wanted to reflag that we are monitoring the Walgreens situation just to get ahead of any potential interruption in the long-term flow of their settlement payments. If there is any disruption there, we will, of course, let the board know. On other settlement news, in the last, I believe, 2 weeks, the Purdue bankruptcy plan was put on file. The solicitation process has started, so that is moving apace. I still don't have any anticipated date when we would actually start receiving funding from the Purdue bankruptcy, but I did want to let you know that that is actually progressing for the first time in a couple of years, actually, it seems like. It may not have been quite that long, but the only other major piece of financial news is that, as I'm certain we are all aware, given the situation with the markets, we are monitoring the ability of each of our corporate to be able to pay. If there is any interruption or change in their ability to pay, I will let the board know as soon as possible so that we can maintain a as accurate as possible estimate of total recoveries that we would anticipate out of the settlement process. And the reason I flag this is, as you know, the settlement payouts for each of the defendants is on a different timeline. And so some defendants, like I believe McKinsey, we just received the final payment of the McKinsey settlement. I believe it's the final payment of the McKinsey settlement. So that one is wrapped up. Some, like Walmart, have already wrapped up entirely, but others will continue going through 2038. So we are going to continue monitoring that situation. We'll let you know if there's any change in the estimates, but I did want to flag that this is the reason we always say these are estimates and are subject to change based on a variety of different conditions. Last thing I wanted to flag for the board is that we are doing our municipalities conference on the 18th, so next Friday. We are very excited about this. I believe we have over 100 individuals signed up to participate in this particular conference. Many of them going to be in person, quite a few online. If there are still individuals who'd like to participate online, we do have availability to still add you to the online portion. Unfortunately, our in-person portion is full. I won't say unfortunately, that's actually very exciting that our in-person portion is full. So we're looking forward to that, and hopefully we can get a lot more engagement by our municipalities and how to use these dollars, get some good educational opportunities, and hopefully open a bunch of new conversations that have previously not yet happened. I'm happy to stand for questions, or sit for questions, as the case may be.
Thanks, Chris. Questions for Chris? Seeing
Chris,
none,
this is Sarah.
that is exciting that you're filled up there for the upcoming conference, Sarah.
I'm wondering, I will be there. I'll be present at the municipalities conference. Are there other members of the board that will be attending?
I have not checked the entire membership list, so I'll let the board speak for themselves if they're planning to attend.
Sarah, this is Mike, and I got kicked out. They're only doing 2 spots per organization, even though my organization has 5,000 employees. We had to pick 2, and so so being that I have constant access to Chris, I gave up my spot. So,
Mike, I'm very sorry. We only have so much money for food, and so we're trying to be very economical here.
And honestly, that's probably a conversation we should have had a couple, whether or not we wanted some kind of board participation in this particular conference. Yes, that does come at a cost, but just being present and kind of knowing what the whole picture is. So maybe something to think about in the future.
Very good. Yes, and I will tell you, I do anticipate that the focus of this conference was really on engaging municipal organizations in conversation and kind of a education focus rather than the whole picture side of things. I think that piece is going to be quite small for this particular particular conference, but we are happy that you're going to be there. Mike, if you did want to attend, I think we can probably fit you in. You just might not be able to get lunch.
Pack your lunch,
I'll
Mike.
share my lunch with you, Mike. Bye.
bring a lunchbox.
Yeah.
All right, any other questions for Chris? Well, thank you, and thanks for being there, Mike and Sarah, and anyone else that wants to join online. And to Chris's point, it probably would be beneficial to the board, maybe at a later time, to schedule a meeting with the municipalities, especially as we get into the collaboration portion of what we're going to do to get their thoughts, and also to let them know what our thoughts are. So thank you, Chris. And now we'll move on to to Krista. Any updates from you, Krista, Sunflower?
Sure. Yeah, I'll be really quick. So we just had one grantee that was awarded in RFP 3 that has had to decline their award. They closed their SED program because of staffing transition. The organization was Link Inc., and they were funded in the amount of $160,000. We tried to work with them to see if there was a potential solution, but since they had to close their entire SUD programming and we're not going to be able to expand as proposed, it was not feasible at this time, but they were encouraged to apply again in the future if the situation changes.
Thank you. Any questions for Krista? All right, now for the main feature. Highly anticipated needs assessment that I know that been worked on CPPR for a while now. And so I'm going to turn it over to Alyssa from Sunflower to make introductions and any other comments. And then from there, we'll pause on occasion for questions. I think will be the best way to move through this. And then also we'll decide as a board on perhaps an interim meeting or two to follow up and to work with CPPR. And those would be done via the WebEx here. So I will turn it over to Alyssa and we'll stand by, and I'll plan to maybe take a 5-minute break somewhere in the middle of our presentation.
Thank you, Chair. So good morning, everyone. So today, CPPR is here. They will be presenting information to provide a comprehensive overview of the report's content, highlighting key findings. We want to thank the board for their patience, and Sunflower is looking forward to supporting the board's next steps as this project wraps up and you all begin looking at the opportunities that will help build a stronger SCD ecosystem. The needs assessment we really see as a first piece of the puzzle. It provides us a solid foundation to springboard the board into more strategic grant making, while the report provides a comprehensive snapshot, as needs assessments tend to do. We also acknowledge that the field is rapidly changing. Resources are changing, and so we want the board to remain to still have relevant and timely context for prioritizing funding, to foster collaboration and drive innovation in the state. So we are excited in May to begin having conversations about that long-term vision and what these next steps look like. So with that, I will hand it over to Janine Huron, and she will go ahead and begin our presentation.
Thank you, Alyssa. Get this where that will work. I think that will do it. Can you hear? My name is Janine Huron. I am an associate director with the Center for Public Partnerships and Research at KU, and I'm here today with a couple of colleagues, Silke von Essenwein. She is a senior researcher at KU CPPR, and Jackie Counts, who was the executive director at CPPR when we started this and has now taken a promotion as the operating officer at KU Achievement and Assessment Institute, our parent organization. So we are privileged, and we know that. We consider it a privilege to have been trusted to do this study. We're excited today to share a high level about where we've been, what we've got today, and where we could go from here. And we'll be going brief here as we can, so I'm skipping through and going right to the start, if we could. Okay, we set out to see the whole system, the substance use disorder system, and here's how we approached it. We approached it by connecting to those who are addressing substance use disorder challenges every day. We reached out to those who currently see themselves on the sidelines, and we've remained mindful that the KFA board itself is a relatively new element to the substance use disorder system, and so we were looking for impressions and reflections and awareness out there for this particular body and the work that you do. We connected directly with a little over 2,000 people in all 105 counties in Kansas, and we incorporated more than 70 quantitative data sources. We started with a secondary data review where we gathered and synthesized reference information that's been written by other Kansas organizations and related task groups and committees, as well as incorporating national and international creative and effective program implementation practices and perspectives. We were very fortunate to have engaged 8 people with lived experiences and diverse backgrounds. They have participated with us throughout this entire last 15 months as consultants to the process and informed us that they would be happy and be prepared to continue as requested in support of the work ahead. They have been remarkable allies and counsel. We met in person, we met online, sometimes one-on-one, sometimes in small groups, broad concepts and strategic concepts, the whole shebang, they were there. Always responsible and responsive with their technical expertise and understanding, as well as their personal views and ideas about advocacy, empowerment, peer connection, and practical solutions. We started in a real public way in March of 2024 with the Community Futures Tour, where we went across the state and visited 11 communities. And we were seeking to garner statewide awareness for the project, and so we began with the end in mind. We focused on both the current state as well as the future aspirations of the people who attended those meetings. This was the beginning of the development of what you will see as the vision. Okay. This was also when we initiated collection of future signals, and this was happened weekly, I think, throughout the whole time frame, where we were collecting ideas through a strategic foresight technique to identify what might be out there, what might be happening that could impact, as Alyssa aptly noted, the rapidly evolving and changed landscape of this work. We did some sense-making work in the early stages as well as in the later part of this process. This is a strategy to understand how people make sense of their experiences, their personal life and their personal experiences, and also the context of their community, what's happening there. It supports the search for the things that we might not know to ask, and it also involves collaborative groups to construct meaning from their collective experiences in specific areas that we were exploring. So those 188 participants in the sense-making attending in the in-person sessions focused particularly on processing the manifestation of stigma. They talked to us about navigating substance use disorder resources. They processed through workforce concerns and also discussion of potential solutions to identified challenges. The sense-making survey was completed by 437 respondents, which provided confidential indication of both personal and family experiences related to substance use disorders. Zilka and her team engaged 150 people in confidential interviews and focus groups. Those confidential conversations were protected by the policies of the KU Institutional Review Board and provided a safe way for people to participate in the discussions with others and accurately and openly share sensitive information without worry or fear. Another generous group of people who have been with us the whole time is a group of about 36 specialists and experts in data consultation with our quantitative team. These are people from across the state who are working in the field every day, and they're responsible for gathering and distributing statistics concerning key programs and statewide information that can be shared then to other professionals. They have been also very responsive, contributing their information as well as thinking through challenges and opportunities and what it might mean, what we're seeing in the data. We had input from multiple surveys and internet discussion strategies, over 459 people. There were 4 topic-specific surveys, and then additional people providing focused input to the surveys themselves, as well as on formative concepts as we were processing, and ultimately on the recommendation and the strategies. And the end of that was the webinars and our listserv. There are 729 people engaged in that way. We produced 6 one-hour lunchtime seminars, as well as continued to gather momentum. We still continue to gather momentum on people who are interested in hearing more and being in the know. The point here was to build awareness and participation for the needs assessment process and an opportunity for people to engage with us directly, but also to provide opportunity for people across the state to share and discuss their work with others. This ability to bring people together and to share in a meaningful way is an exceptionally important piece of this work, and let me show you why. See if I've got it. What you're looking at is one of 8 maps representing substance use disorder domains and adjacent systems at work. I should have turned that off. This one is specific to the provider types within the treatment domain. These maps are not a destination, and we won't walk you through it unless you want to. That's not what it's about. But what we were looking for is who is out there, the relationships between those players, and the overall infrastructure currently in place across the state. And one thing these maps all have in common is that they all look like this. The challenge we have is the fragmentation that you're seeing, which is characterized at the systems level by uncoordinated programming, inconsistent referral pathways, and siloed information and data systems. That makes it very difficult for the people who are working in the field to access and navigate care, as well as ultimately can have negative effects and long-term recovery outcomes. On the day-to-day, that translates this way. It's confusion for individuals and their families and loved ones who are seeking resources. It is a lack of interaction between individual service providers who may be working with the same individual. It affects professionals like the data specialists I just spoke to in terms of their ability to convey the information that they need to convey and get that into the dialogue. And it makes it difficult for funders to braid resources in a coordinated way. You'll hear us talk about this in a little bit here. It also further weakens the linkages between our substance use system and adjacent sectors like social services and law enforcement and legal systems, as well as healthcare. Any way you slice it, in order to benefit in the system, you have either got to be in the know or really lucky. And we'll see that as well. So let's talk about that individual experience, okay? We asked the accountability cohort in their very first meeting to share their individual stories, and each person did that wholeheartedly. They laid out their journey and were unique in the things they chose to highlight and the words they chose to use. When they identified words or phrases that were how they were thinking about their experiences, that created what you see on this slide, which is some experience signposts from which we could extrapolate and get additional feedback throughout the state. Entry points or initial recollections centered on early trauma, and at some point there's a realization that there's a problem, right? The control is elusive, and there's a tipping point. This was most often not a singular moment, but a gradual experience. The cohort used a range of descriptions to describe their interactions with the substance use systems, and they fell into three groups. The first there was the intense stigma that they felt. The comment that particularly gave me pause was when one of the individuals declared, "We're just the new Jim Crow. We're caught in the ugly ways of thinking about people who use illegal substances." Treatment approaches that mimic or perpetuate the judgment was another category here. They talked about the outsized reliance on law enforcement and corrections to provide treatment. And one person described the betrayal this way: "They just lied to us." This is the people in the prison that he was in. "They just lied to us. All the training and things that we did all day were just a way to keep us busy while we were in prison. The day you leave, you realize there really aren't any jobs, and you're back to square one, and this time with a felony record." So in that case, a positively contributing individual in this community was in this cycle of 6 progressively more stringent correctional placements over 9 years. So the point is that it can take a long time in that section of fear and judgment. The time a person remains there also, I'm trying to go fast and I'm skipping things in that I should just read. The time the person remains in the cycle can be long, and a clear takeaway is that any system-level solution needs to address all 3 of the factors that we see here. At a minimum, we need to acknowledge that they exist, because otherwise what happens, as they describe, is that the situation spirals into kind of an ultimate low point that they called lack of mattering, One individual related that they thought real treatment just wasn't for them, that it would never happen, and I thought this was just my lot in life. So that lack of mattering was experienced differently by different people, but it was consistent across everyone. Sometimes this was an accelerant for the stigma treatment root cause cycle, or sometimes it served in this sort of traditional rock bottom role where the next steps would begin recovery. One thing that's really important to note here is that none of this is linear. Addressing any one category on its own leaves individuals in a vulnerable spot, and that is another reason why cohesiveness in our systems is very important. Lived experience experts also shared as much, if not more, about their connection points in the SUD cycle relating to recovery and that process of change. The experience elements here, once again, was different for each person. Recognizing that there are processes for change is one of those. Precise and effective diagnosis and treatment. Misdiagnosis was a really common theme from every direction, as the lack of connection between mental health care and substance use care was separate and distinct, and a combined approach is really the evidence-based way to get the best response and the longest lasting supports. The importance of the accurate diagnosis, simultaneous treatment for mental health and substance use are validated in study after study. Recognition of the nuances of the disease and the duality, such as work and corrections, as things that you do or that are done to you, rather than who you are as a person. It's about their behavior rather than who they are and what they may need. Also, a set of criteria for substance use recovery is elusive, and it was different for each person. That underscores the importance of individualization and really the wide variation in the terms on how individuals come to realize health. Connection to others, leading to community and belonging, was by far the most pervasive outcome as people regained their personal strength. That was the point at which they expressed, I knew that I was beginning to reconnect again. I had purpose. I got up in the morning and I knew what I was going to do and why. Community, belonging, and purpose. We'll hear a lot about that as we go forward. Nobody used the phrase, I got better, and that was important as well. And they explained it this way. They said, this is a change rather than some broad brush self-improvement focus. And it's important to acknowledge me as a human with dignity, that I wasn't bad before. So I'm not suddenly a better person now. So we were cautious about that as well. Okay, so let me tell you a little bit about the report itself. We have 5 components here. The vision that represents the aspirations expressed by people across the state beginning last March. That is defined by the tenets that describe what that vision looks like day to day on the ground. The vision and tenets create the foundation for the overall recommendation, which is informed by the key priorities that were identified in the research. We've then also identified the strategies and tactics that can be used to actualize the desired outcomes expressed in the priorities. So let's explore that a little bit here. Okay, in the vision, that's in your handouts, and it's also here on the screen for those who are remote. But the hallmark attributes of the vision are really compassion and understanding. And that understanding is that this is a preventable and treatable chronic condition requiring ongoing community involvement and support for healthy functioning. It also recognizes that a collaborative system of players are essential to integrated and cohesive support. Here again, we spell out the tenets and we go into much more detail in the actual written report, which will be delivered on or before the 30th of this month. And here's how we spell those out, with emphasis on the relationships between individuals and communities. And you can read the words for yourself, but I'll go forward here to a diagram that we have found really helpful. The recommendation ultimately is assuming a public health approach toward our systems in the substance use area. What you see here is the individual. The individual is the central focus, where we emphasize each person's values and strengths, and where their access to substance use systems resources is understood to be a universal right, and where those interventions are flexible with individual defined desired outcomes. They're surrounded there by that green ring, which is the community. And that is a community that anticipates and responds to the needs of its residents, and particularly the health of the children and young people there. And then in the blue, for the benefit of individuals and communities, is the coordinated and ongoing support for substance use disorder, with emphasis on measuring the health of communities rather than placing a burden of illness on individual residents. Okay. So with this, I'll pause here and can turn the program over to my colleague, Silke, to share some specific insights from the research.
Thank you.
Good morning.
Good morning.
There we go. I want to start kind of big. I want to talk about that substance use is much more common in Kansas than a lot of people realize. So based on recent survey data, about 1 in 5 adults in the state, about 400,000 people, meet the criteria for substance use disorder. It's especially common among young adults, ages 18 to 25. In that group, nearly 1 in 3 meets the criteria for SUD. This tells you that it is significant, and especially during key transition times. As we move forward through this presentation and in the report, you'll see a lot of numbers and charts and tables like this. But I don't want them to lull you to sleep. I want to tell you that they're going to give you practical, actionable data that you can refer back to when you're planning funding and when you're developing programs. The key takeaways from this chart is that substance use is widespread across Kansas. When we look more closely by age, some important patterns emerge. Alcohol use is high across all age groups. More than half of the adults report using alcohol in the past month. Young adults have the highest reported use of marijuana and other drugs. And yet they're one of the least served groups in what we've found. The system isn't built right now to meet their needs, schedules, and their transitions. Methamphetamine use, while it looks low overall, is quite common among adults over 26, particularly in rural and uninsured populations. Something we'll talk about a little bit more later. And finally, while overall use among adolescents is lower compared to adults, those who are using substances often start early. For example, 9% already meet the criteria for substance use disorder. That's where early intervention prevention is especially critical, with the right supports in schools, communities, and mental health services. There's a meaningful window to change the trajectory early on. So again, keep in mind, these charts start the report aren't just data for data's sake. They're tools for action. They'll help identify who's using substances, where gaps in services exist, and where the biggest opportunities for impact may lie. Now that we've seen how substance use plays out across age groups in Kansas, it's important to step back and ask, why is this happening? Across Kansas, the use of alcohol and other substances is deeply normalized. From tailgates to town fairs, drinking, and sometimes drug use is just seen as part of the experience. But that normalization comes at a cost. It can mask real risks and delay people from recognizing when they might need help. Young adults in particular reflect this cultural influence. In Kansas, only 34% of people ages 18 to 25 believe binge drinking is risky, one of the lowest perception rates in the country. In community conversations, we heard over and over again that excessive drinking is treated like a rite of passage, something you're expected to do as part of growing up. Meanwhile, substances like marijuana are becoming more popular with young people. Why is that? It's cheaper, it carries less stigma, and it's often seen as more discreet or manageable. And you don't drink a lot of empty calories, we've heard several times. Here's one of the most striking pieces from the NISTA data, from the survey data that we have this data from. Over 90% of people who meet the criteria for substance use disorder don't believe that they need help. There's a big gap between the actual need and the perceived need. And this gap is made worse by stigma, especially around substances like opioids and methamphetamine. Even when people do realize they need help, stigma can make it incredibly hard to reach out and access services. So we're facing a double challenge, a culture that normalizes substance use and stigma that blocks support. This mix makes it tough for prevention, early intervention, recovery to gain ground. If you want real change, we have to address both. These cultural attitudes don't just influence how people think about substance use, they also affect how, when, and where people get help. Middle-aged adults, especially those between 35 and 54, now have the highest overdose death rate in Kansas. And the burden is not shared equally. Black Kansans experience highest overdose death rates in the state, more than double that of white residents. Together, these data points underscore how often individuals with substance use disorders in Kansas are interacting with the system during moments of acute need, but not necessarily receiving sustained care. Across the state, we found that fifths, or over 20% of all patients receiving SUD services require emergency or crisis care, indicating that many are only reaching services when they're actually in distress. At the same time, among all overdose deaths in Kansas, only 5% of those individuals had a documented history of treatment. That means 95% of those who died had never connected with formal care. These patterns point to critical missed opportunities for earlier intervention and stabilization, suggest another stronger focus on outreach, low barrier entry points, and continuity of care could prevent crises and save lives. And sadly, even when help was physically nearby, it wasn't enough. In nearly half of the fatal overdoses, a bystander was present, but fewer than 10% of those that were there stepped in or tried to help. That's far below the national average, where intervention happens about 30% of the time. This gap points to a clear need in Kansas. We must expand access to naloxone, provide bystander training, and normalize harm reduction strategies in our communities. People want to help, but they need more than just tools and training. They need confidence, support, and the assurance that stepping in won't put them at risk. Without that safety, hesitation can cost lives. Empowering bystanders means equipping them with naloxone and removing the fear of consequences when they try to save somebody's life. But as we think about what it will take to reduce overdose deaths, it's important to recognize that the landscape is still evolving, and it's evolving very quickly. This brings us to this next idea, chasing the Red Queen. The image you see here is from Alice Through the Looking Glass by Lewis Carroll. In it, Alice is running alongside the Red Queen, but no matter how fast they run, they stay in the same place. The red queen tells her it takes all the running you can do to keep in the same place. We're using this image because it's a fitting metaphor for where we are right now in the fight against overdose. New synthetic drugs like nitazenes and xylazines are emerging that are resistant to standard overdose reversal agents such as naloxone. These substances are more potent, more unpredictable, harder to respond to, and they're not being tracked really well right now. What this means is we're constantly having to adapt just to keep up with the changing nature of the drug supply. So it's not just about solving the current crisis, it's about being prepared for what's coming next. To make progress, we'll need to move beyond reacting and start anticipating. That means building a system that's flexible, responsive, and informed by real-time data and communities' insights. While these types of substances may be evolving, the geography of overdose deaths also tells an important story. This slide looks at non-fatal overdose incidents across different counties in Kansas, grouped by how urban or rural they are. The data show that urban counties like Shawnee, Wyandotte, and Sedgwick have the highest incident rates. That's probably not a surprise to anybody here. But for many, this won't be surprising. You know, they have larger populations, more visibility in the data. But what's important to notice is that non-urban counties are also clearly impacted. Counties like Pawnee, Atchison, and Elk, classified as rural or even frontier, still show significant overdose rates. So this is actually the top 10 counties in the state right now. Even the total number of cases is smaller. This challenges the assumption that substance use is mostly an urban issue. In reality, the crisis is everywhere, and communities of all sizes need tailored resources, response systems, prevention strategies. It also highlights the need for local health systems, especially in rural areas, so that they're equipped to deal with whatever comes their way. To address substance use effectively, we also have to take a look at the bigger picture, not what just happens during treatment or crisis, but what leads people there in the first place. The substance use doesn't happen in a vacuum. It's often rooted in deeper challenges related to health, housing, and social connections. Before we go any further, I'm a biologist, so I have to put a little caveat in. It's important to acknowledge that biology matters. Research shows that 40 to 60% of persons' risks for developing a substance use disorder is linked to genetics and other biological factors. This includes things like brain chemistry, family history, and how a person's body responds to substances. But biology doesn't operate in isolation. The environments people live in, their housing, relationships, opportunities, and supports all influence how biological risks play out in real life. These conditions can either buffer that risk or make it harder to manage. On the right, you'll see 4 broader dimensions that shape both risk and recovery. These are areas where systems, communities, and policy can make a real difference. Health, including both physical and mental health, home, access to safe and stable housing, community, purpose. And when these foundations are shaky or missing, people are more vulnerable, not just to substance use, but to a range of challenges that can compound over time. It's important to understand these root causes so we can shift the conversation from what's wrong with this person to what's happening around them. And that opens up more for meaningful long-term solutions. To better understand the environment that substance use happens in Kansas, we built on the vulnerability index originally developed by KDHE. Their framework was a very strong foundation, but we took the opportunity to add additional dimensions, especially those related to social determinants of health. So we expanded the vulnerability index to have over 20 factors that include things like food security, social support and connection, access to childcare, and community environment. On the left, you see how these vulnerability indexes then shake out in terms of scores. So these clusters reflect different combinations of structural stress, stability, and risk exposure. On the right are some of the predictive factors that we included. So here is how the map looks like. Every county on this map is color-coded based on the overall level of vulnerability. So the darker red is a very high vulnerability group. Counties in lighter red are low or very low vulnerability. This map highlights that vulnerability isn't just about overdose rates or treatment access. It also shaped by the broader conditions people face. That means also that a shared vulnerability score, so everybody who ended up in the same color, is not the same, and a one-size-fits-all response won't work. What's fueling substance use in one area, like lack of housing and employment, might look very different in another, where provider shortages or transportation are the bigger issue. And those differences matter because they shape what kinds of solutions will actually work in each community. Tailored, locally grounded strategies are essential. So here we want to give you an example how you can use the data you're going to be getting from us to tailor interventions. And you see 3 counties that fall into the very high vulnerability group, Sedgwick, Saline, and Wyandotte. But as you'll see, the issues they face aren't the same. To the right, you see what's called a radar chart that helps visualize these differences. Each colored line represents a county. Orange for Sedgwick, blue for Saline, gray for Wyandotte. Each point on the chart corresponds to public health or behavioral risk indicators, including overdose incidents, HIV and STD prevalence, homelessness, liquor store density, lack of physical activity, or lack of leisure time. The farther a point from the center, the higher the rate for that issue in that county. Sedgwick spikes on overdose and STDs, indicating high levels of acute need around both substance use and infectious disease. Saline shows elevated rates of homelessness and high alcohol access, paired with limited physical activity, pointing to community conditions that may erode protective factors. Wyandotte trends high across nearly all indicators, particularly HIV, inactivity, and overdose, suggesting more systemic layered risk. These differences illustrate a crucial point. Even when counties fall into the same vulnerability category, the specific risks and needs beneath this label can vary widely. And it means solutions must vary too. For instance, Sedgwick may benefit from expanded harm reduction and stronger preventive care infrastructure. Saline might require housing investment, alcohol zoning reform, or wellness programming, while Wyandotte likely needs comprehensive wraparound supports grounded in public health and community outreach. This kind of comparison helps move us beyond a one-size-fits-all intervention and towards place-based strategies that are grounded in the data and aligned with the realities of what each community is facing. Up to this point, we focused on a lot of systems, environments, and data. We talked about stigma a little bit already, but I want to really take some time to talk what we found. And we found that stigma can show up in many forms: judgment from others, self-blame or shame, discrimination in healthcare, employment, and housing, reluctance to seek help even when it's needed. For rural and tight-knit communities in particular, stigma can be even more isolating. People may fear being recognized at the clinic, talked about at work, judged by neighbors, or even running into the provider in the grocery store. If we want people to access care, stay engaged in recovery, or even just feel safe talking about what they're going through, we have to address stigma as seriously as any other barrier. Because no matter how strong our system is, if people feel ashamed to use it, we're still going to fall short. So where does it actually show up? We found, a surprise to most people, that stigma is widespread and embedded. And we have this graphic to try to show the person in the center who may or may not have self-stigma. And they might encounter a healthcare and behavioral healthcare system where they may be judged, dismissed, or denied care. Employment and housing, where substance use history can limit access or lead to discrimination. Education sector, especially for youth and their families. Public safety in courts, where substance use is often punished instead of treated. Faith communities, and even peers, where negative attitudes can reinforce shame. We already talked about that 95% of people who meet clinical criteria don't actually think they need treatment. So while policy, prevention, and care systems are critical, none of them will work if people don't feel safe using them. For many families, stigma takes the form of silence, judgment, and isolation. This quote from a parent says it plainly. When their child was struggling with substance use, they felt invisible, unsupported, like they were being quietly written off. And that kind of exclusion doesn't just hurt emotionally. It limits opportunities for connection, treatment, and healing. But here's the good news. People with lived experience are powerful agents of change. When we make space for their leadership, visibility, and stories, we help dismantle stigma from the inside out. Whether through peer support, advocacy, or simply by being visible in recovery, people with lived experience remind us that recovery is possible and that everyone deserves to be seen, supported, and included. One place where this challenge is especially urgent is within the healthcare system itself. This quote from a primary care doctor reflects something we've heard from many providers, a recognition that substance use is still too often treated as someone else's problem, rather than part of the broader healthcare mission. That failure has consequences. On the right, we've outlined a few. Patients often feel judged and dismissed. The provider-patient relationship becomes strained. He's marked by mistrust, frustration, fear, and discomfort. And people are less likely to return to treatment, not because they don't want help, but because past experiences have taught them to expect rejection. Even the SUD workforce, peer specialists, recovery coaches, counselors, often feel like second-class providers in clinical environments, despite their essential role. But here's the good news. This is starting to change. We're hearing from both community members and professionals that stigma is being challenged, not just with words, but in action. More healthcare providers are recognizing substance use as a health issue that they have a role in addressing. More systems are integrating recovery-oriented care in their services. And more people in recovery and their families are stepping into visible, respected roles. So while the challenges are still real, there's momentum, and that gives us something to build on. As we think about the role of systems in either supporting or undermining recovery, we also have to talk about how laws and policies are applied and who they impact the most. This quote from a public defender is intentionally blunt. It reflects a growing frustration with how the system responds to substance use. If I go home and beat my wife, but I use meth, the meth would put me in prison longer than the beating my wife will. That's absurd. It's a striking example of misaligned priorities, where substance use, a health condition, is often treated more harshly than behaviors that cause direct physical harm to others. On our right, we've outlined just a few of the policy concerns raised across countries. Alternative courts are well-intentioned, but they're costly. Not everybody has access to them. They run inconsistently across the state, and they're hard to navigate, especially if you don't have stable housing or transportation. Overall, court and probation requirements can create rigid conditions that work against recovery. And people with SUD-related convictions often face long-term exclusion through felony records or registry listings, keeping them out of jobs, housing, and community life. There's increasing support for a sentencing grade reform aimed at aligning penalties with the nature and context of the offense, while also reflecting our current understanding of what drives substance use, including trauma, lack of mental health care, and social environmental determinants. And here's really the bigger underlying issue. These policies are still deeply shaped by stigma, not science. They reflect outdated ideas of substance use as a moral failure, not the complex chronic health condition it is. They also place a massive burden on the public safety, court, and penal system, systems that were never designed or equipped to handle health issues like substance use. Law enforcement ends up acting as first responders to mental health and substance use crises. Jails become de facto detox centers. Courts are left to manage recovery, something they're not structured or resourced to do. This approach isn't working, not for the people in recovery and not for the systems trying to hold it all together. I want to look at one of the biggest drivers shaping how people actually move through the system, and that's coverage, so insurance coverage. So coverage, whether through Medicaid, Medicare, private insurance, or block grant programs, play a major role in determining who gets access to care, what kind of care they receive, and where they can get it. The work we have done in this needs assessment represents a major step forward in understanding SUD services, access, and delivery across Kansas. Thanks to the strong collaboration with our community partners, we've been able to bring together claims data from Medicaid, Medicare, block grant, and commercial insurance and pharmacy data that we purchased through IQView into a single view. This allows us to analyze patterns across systems, helping us better understand who is receiving and providing care, where services are being delivered, what are the dropout rates and follow-up rates, what type of treatment diagnosis are people getting? What are the prescription trends and treatment pathways for people? This kind of insight is valuable for shaping more targeted, coordinated, and responsive systems of care across the state. While claims data naturally focus on billable services and may not reflect everything that happens outside the formal system, it still provides one of the most comprehensive snapshots we've ever had of the SUD treatment landscape in Kansas. The integrated claims data gave us an enormous amount of information inside, far more than we can fully cover here, even though I would love to take up the next 6 hours of your life to talk about everything because it's very interesting. But we're going to share just some few key highlights, just some of the key takeaways that stood out to us and help illustrate how coverage types shape the treatment landscape in Kansas. This very pretty, colorful chart breaks down into 4 payer categories on the left: commercial insurance, Medicare, Medicaid, and block grant funded services. Each bar represents the substances people are being treated for by that payer, and some clear patterns emerge. Alcohol use disorder is the most common across all payers, but especially dominant in Medicare and commercial plans. Reflecting both its broad prevalence and its impact on older adults and individuals with disabilities who qualify for Medicare. Opioid treatment shows up fairly evenly across payers, but especially notable in the Medicare population. Methamphetamine use is a major driver of treatment among block grant recipients in Medicaid, signaling significant role in uninsured burden. The NISTA data does not collect polysubstance use disorder, but this data allowed us to actually look at what the percentage is in terms of at least who shows up as using more than one substance in their billing data, and we found that over 20% of people have a formally diagnosed substance use disorder from more than one disorder. This rate is actually highest in commercial at about a fifth. About a third of Medicaid patients and 15% for Medicare. This breakdown helps us better understand not just who's receiving care, but what kind of conditions our systems are being asked to treat, and how that varies by population and coverage source. These differences matter because they shape the types of services needed, the workforce required, and the settings where care should be delivered. One important thing I really want to point out here is that how much commercial payers are involved in SUD treatment in Kansas. Commercial plans pay for about 38% of all treatment episodes in Kansas. That's a significant share. And it underscores the importance of including commercial insurers in conversations about system coordination, quality standards, and access improvements. We often focus on public payers like Medicaid or block grants, but commercial coverage plays a key role in the states, especially for working-age adults, families, and people who may not otherwise be eligible for public services. And we have data for you about how treatment patterns and treatment quality differ across payers, which has big implications how we think about workforce needs, provider networks, and service design. Block grant funded services support the largest share of people receiving SUD treatment in Kansas, a little bit more than commercial, covering just about 40% of all patients. This funding stream is especially critical in reaching people who are uninsured or living in rural areas, where other coverage options may be limited. They also play a central role in responding to methamphetamine use. Nearly 40% of all block grant clients are being treated for methamphetamine use. In fact, they told us that the bulk of their treatment funding goes towards methamphetamine treatment. And the implication is clear. Block grant funding is not a backstop. It's a backbone of the SUD treatment system in Kansas. While Medicare accounts for just over 6% of the overall treatment options, the data reveal important patterns that warrant greater attention. This group includes not only older adults, but also people under 65 with disabilities, many of whom are navigating multiple overlapping challenges like chronic health conditions, fixed incomes, limited mobility, and social isolation. The ripple effects are wide-reaching. These individuals often rely heavily on family members, unpaid caregivers, and a strained healthcare system for support, placing a significant burden on those networks without adequate tools or resources. The implication is that Medicare isn't the biggest payer in the state. It supports a population with complex and compounding needs. Failing to address substance use in this group not only jeopardizes individual outcomes, but also places pressures on hospitals, aging services, and caregiver systems already stretched thin. Investing in better SUD integration in Medicare, particularly through primary care, home health, and aging disability services networks, is essential to preventing gaps in care and protecting people and the systems that support them. But even with multiple funding streams and service options, the majority of Kansans with a substance use disorder are not receiving treatment. This chart shows treatment need by insurance type. And in every category, the unmet need far exceeds the number of people actually receiving care. This is even especially stark for those in Medicaid and Medicare. Now, the uninsured, the block grant covers a lot of the need, but there's still a large gap for having everybody that wants to get coverage. Among all of those covered, youth, so under 18, and older adults over 65 have the lowest rate of treatment access across all insurance types. And notably, 1 in 6 people in Kansas have to leave the state to actually get treatment, and most of these individuals are actually from frontier counties and over 65. So this pattern suggests challenges that go beyond coverage alone and may also reflect geographic gaps and limits in serviceability, particularly in more remote areas. The implication is that expanding coverage alone isn't enough. To close treatment gaps, Kansas will need to invest in locally accessible services, especially in frontier and rural areas, and build solutions that are responsive to the needs of both older adults and youth. So we looked at the overall action on access and coverage. But even among that do get treatments, what they receive and how effective it is depends heavily on where they live and how they're insured. This slide highlights a critical issue in the state, the underuse of evidence-based care, including medications for opioid use disorder, medical detox, and flexible options like intensive outpatient programs or partial hospitalizations. A primary care physician we spoke with said it plainly. A lot of what we do in substance use treatment is not especially well researched or evidence-based. But two interventions that save lives are buprenorphine and methadone. We need to be in life-saving business. And the data backs that up. In 2023, less than 4% of people in treatment received medication for opioid use disorder. Now, the block grant funds over 60% of all medication MOUD use in the state. That makes them the single most important payer for this life-saving intervention, but also highlights how dependent the system is on limited public funding to deliver core services. We see similar challenges with flexible care models, where few people have access to flexible care model, outpatient, partial hospitalization. Most of those are covered by commercial insurers. Medical detox is virtually non-existent in the state, at least from the billing data, but also, again, people with commercial insurance have the best access to it. If we want to close treatment gaps and save lives, we need to do more than expand access. We need to expand the right kinds of care in the right places for the people who need it most. And that means funding more access to medication in Medicaid, Medicare, and uninsured populations, and really across the board. Supporting flexible models, especially in underserved areas. Addressing detox access in treatment models in rural and frontier counties, and overall. We really need to strengthen the block grant infrastructure that's already doing so much of the work. And we need to help providers offer faster, more coordinated care, so people don't have to wait 6 months or more to get help. And our wait time data is pretty hard. So we do have a fair amount of people that can access same-day access, but it's mostly due to commercial insurance. But wait times of 6 months to a year are not uncommon to get into treatment. Yeah. So far, we focus on the types of treatment cancers are and aren't receiving, on how that varies based on insurance type and geography. But behind all this is a bigger question: how are these services funded? So we looked at the role of grants and other funding in supporting the continuum of care. In Kansas, core funding streams like Medicaid, Medicare, and private insurance shapes access, but they don't cover everything. Many of the services that are hardest to build or most critical for high-need communities are being supported through grants, block funding, and local initiatives. This includes medications for opioid disorder. I already talked about that block grant dollars fund more than 60% of the patients receiving MOUD in the state. Prevention, case management, harm reduction, and outreach, services that often fall outside traditional billing models. Grants aren't just filling gaps, they're propping up the entire system. And as we're spending opioid settlement funds, there's a real opportunity to ask, what can we build on? What should we scale? And how do we make sure funding aligns with need, and not just reimbursement rules? So let's look at a closer look how grant dollars are already being stretched to support key parts of the treatment structure, and what risks we face if they're not sustained. One of the biggest challenges in Kansas substance use treatment system relies heavily on short-term grant-based funding. Right now, about 2/3 of all SUD funding in Kansas comes from federal sources, and most of it through time-limited grants. And while that funding has been vital, it tends to be reactive, meaning it's designed to respond to crises or specific issues after they arise, rather than allowing communities to plan proactively. For example, grants may target overdose spikes, stimulant use, or emerging threats. But they often come with tight timelines, rigid scopes, and little room for long-term planning or infrastructure development. There's also growing uncertainty about the future of federal funding streams. Many current grants are nearing the end of their funding cycle, and it's unclear whether reauthorization or renewal will happen, or what level. At the same time, we saw some long-term funding opportunities go unclaimed, simply because communities lack the staffing capacity to apply. That's a missed opportunity to build more stable foundations. We know that system building works, and states that have invested directly in core infrastructure, like through Medicaid expansion, are seeing stronger care networks and better outcomes. So for Kansas, this is a critical moment. Rather than relying on short-term patchwork solutions, we need to ask, how do we stabilize what's working now? How do we diversify funding? And how do we build partnerships that make it easier to braid and sustain resources over time? If we want long-term solutions, we need long-term strategies, not just short-term fixes. And now, do we want to take a break?
Mr. Chair, this would be a good point to take a break if you're so inclined.
Yeah, let's take a short break. Again, we're trying to, we want to be done by around 11:30 today, and then we can do a follow-up. So we'll break for 5 minutes and come back. It's like we can go ahead and call the meeting back to order here, and I would just my recommendation would be is kind of at a high level go through the slides until we get to maybe 36, where you have workforce needs, and then getting into the priorities and strategies would be a good place to go from here.
That's what we will do. So as we think about strengthening Kansas' response to substance use, we can't just focus on treatment access. We need to invest in prevention and safety strategies, the kinds of supports that reduce risk, protect lives, and help people stay well over time. When it comes to prevention, Kansas has historically underinvested. Just a small fraction of the state's substance use funding goes towards primary prevention, although things are changing. And much of that is limited to short-term grants, narrowly focused programs, or efforts that only respond after problems have already emerged. But we know that prevention is powerful when done right. One-time classes or lectures don't move the needle. What makes a difference are consistent, relationship-based, and trauma-informed approaches that are built into people's lives and communities. This speaks directly to the importance of mental health access as a pillar of prevention. If people can't get support when they're struggling, or if they don't feel safe or welcome doing so, they're more likely to cope in ways that increase risk. And while a lot of prevention effort focuses on young people in schools, we have to recognize that not all youth are in school. Unhoused youth and those disconnected from traditional systems are among the most vulnerable and too often overlooked. We also can't ignore prevention across lifespan. As we've seen earlier, young adults have the highest substance use rates in the states. Middle-aged adults have the highest overdose death rates. Older Kansans and caregivers also experience stress, trauma, and isolation, all of which can increase substance use risk. That's why we need approaches that are intergenerational and are offered across the lifespan, that support families and communities together. Safe environments are essential. We saw that early in the vulnerability index, physically, emotionally, and socially. Risk clusters around factors like housing instability, food insecurity, and limited access to care. If we want to prevent substance use, we have to start by strengthening the foundations that support mental and emotional well-being. So the takeaway is this: prevention is not a one-time event, it's a long-term investment. It means prioritizing evidence-based, mental health-aligned strategies that reflect the realities of people's lives, and making sure the strategies are reaching the people and places where they're needed most. But prevention is only one side of the equation. To build a truly effective and compassionate system, we also have to focus on what happens after treatment begins and continues. That brings us to the next piece: follow-up care and recovery support. Our data clearly shows that dropout rates are very high. They're at least 50, they're actually highest in the Medicare population, and that there's not enough long-term follow-up care happening once people leave the acute treatment setting. Recovery is not a singular event, it's a sustained process. Yet our system is often designed around short-term treatment episodes with little infrastructure to support the ongoing work of staying well. To address this, we must begin build a recovery-oriented system of care. This includes peer support, recovery coaches, case management, and navigation services, all of which have been proven to improve long-term outcomes. We also need to strengthen re-entry and transition supports, especially for individuals exiting incarceration or residential treatment. These are some of the highest risk moments in a person's recovery journey, and they require thoughtful, sustained support. Providers must also be supported and incentivized to stay engaged after discharge through scheduled follow-ups, mobile outreach, or virtual contact. But again, recovery is not linear, and the system and our system needs to reflect that. Just as importantly, we must invest in the social and structural supports that sustain recovery, especially housing, employment, and transportation. These are not extras. They are essential to creating the stability that long-term recovery depends on. And finally, we must normalize long-term care. As with any other chronic condition like diabetes or heart disease, substance use disorders require ongoing management, not a one-time intervention. Settlement funding offers a unique opportunity not only to fill gaps, but to build a lasting system. This is where we shift from managing crisis to supporting recovery for the long term. We just talked about the importance of supporting people beyond the treatment services and making sure they don't fall through the cracks once formal services end. But the reality is many Kansans never make it to treatment at all. They're navigating substance use while facing stigma, instability, or fear of judgment. And that's, we also need strategies that meet people earlier, where they are without conditions. At its, At its core, harm reduction is about safety, dignity, and connection. It focuses on keeping people alive, healthy, and engaged long enough to see a pathway towards recovery. Some strategies are broadly accepted and happening in Kansas, like the naloxone distribution. We find that has really made huge strides. So between 2021 and 2023, the naloxone distribution tripled in the state from just around 16,000 doses to over 50,000. And we were able to show that just a 10% increase in naloxone is related to overall overdose reduction rate of the same size. Fentanyl test strips have also been shown to be effective in Kansas, but there's a lot of room to grow to get them out more. There are other approaches, like leave behind kids syringe services or drug checking sites that sometimes raise concerns. But it's important to understand these are not about enabling substance use. They're about reducing disease, building relationships, and creating safer environments while individuals consider next steps. And critically, research shows that these efforts do not increase drug use. What they do is increase survival, stability, and eventual engagement in care. This board has a real opportunity. Right now, harm reduction services are limited and unevenly available across the state. With the emergence of new and more potent substances, the need is growing fast. This is a chance to expand the reach of proven, life-saving approaches and help communities respond before the crisis deepens. These strategies can and should be tailored to reflect local values and priorities. Harm reduction is not a one-size-fits-all model. It's flexible, practical response that meets people where they are. This is about saving lives. It's about protecting families and keeping communities safe. And it's a smart, data-driven way to use opioid settlement funds. None of the things we talked about today are possible without the right people in place. From outreach to peer support to clinical care, workforce is the thread that connects every part of the system. And right now, that thread is stretched thin. The next slide shifts our focus to what's going to take to build and sustain the workforce you need for a public health-oriented model of care in Kansas. This is a map that you're going to have access to. It's one of the maps from ArcGIS. This map gives a snapshot of where substance use disorders providers are currently located in Kansas. And some patterns quickly jump out. You obviously see a strong concentration in urban centers like Wichita, Kansas City, and Topeka. And in many rural frontier counties, access is sparse or non-existent. We thought it was very interesting how all its dots following these like lines, like pearls on a string, and they're following the roads and the towns that are there. This matters because nearly 1.2 million Kansans live in areas designated as mental health professional shortage zones. That's not just a statistic. It translates to people going without care simply because there are no providers nearby. But the solution is not building more treatment centers. There are real opportunities to expand access by using what we already have, from hospitals to primary care to pharmacies, especially in rural areas. This is why these provider maps are part of the dashboard tools you will be receiving from us. They allow you to explore what's available in a community, what services are being offered, and where new investments could make the biggest difference. The backbone of the system is the people. This slide focuses on the workforce, the behavioral health providers, primary care clinicians, peers, pharmacists, and support workers who make care possible. Right now, Kansas is not fully engaging its healthcare system in responding to substance use disorder. Primary care providers, who are often the first point of contact, may lack the training, time, or system-level support to play an active role. And as we pointed out earlier, substance use is often seen as someone else's job. That's a critical gap and a missed opportunity for earlier, more effective interventions. Rural hospitals in particular could be key partners. Many are already trusted anchors in their communities. With targeted support, you could offer outpatient services, deliver medications, or host peer-led recovery and prevention supports. Expanding into this kind of care could also help these struggling hospitals strengthen their financial footing, bringing in new streams of revenue and helping retain patients locally. Pharmacies are another underutilized resource. All but 2 counties in Kansas have a pharmacy, and pharmacists are already authorized to provide naloxone, behavioral health screenings, and MOUD. But they need sustainable reimbursement to fully step into those roles. At the same time, we must support and stabilize the behavioral health workforce we already have. These providers have high caseloads, long wait lists, administrative hurdles, and relatively low pay. Without investing in retention, training, and infrastructure, we risk losing the capacity we have, even if demand continues to grow. The bottom line is this: we're not supporting or activating the workforce we already have. This includes under-recognized peer workers, overburdened clinicians, and under-supported healthcare professionals. If we want to create a sustainable system, we need to just not think about adding more, but about strategically developing, training, and empowering the people already in place, and engaging those that are currently not full partners in the system. And for this board, workforce investment is one of the highest impact opportunities, because even the best strategies and funding won't matter if we don't have people ready and able to carry them out. We just covered a lot, and I recognize a lot to take in, and you haven't even seen most of it. You've seen the data, the gaps, the opportunities, and the real people behind the numbers. There are many decisions ahead, and no shortage of needs to respond to. But what we've done through the work is use the data to help focus the conversation. We've identified clear priority areas, ones that address urgent challenges now, while also laying the foundation for a stronger, more sustainable system over the long term. So as we shift into the next section, we'll walk through the priorities, not just broad goals, but specific strategies and tactics, ones that this board can use to start making real measurable progress in the time and resources that you have available to you. So let's talk about what it means to move from insight to action.
Thank you, Zilka. Thank you, everybody. The priorities and the strategies that Zilka was talking about are in handouts for those who have the handouts, and that is the full version of those. And I'll walk through an abbreviated version and really just talk about how that works and the structure of what we're doing here. Just pausing, when you see the actual assessment report itself, what you'll see is that the report has been intentionally developed to mirror elements of comprehensive strategic planning. And so we intended that as a potential bridge for you between the needs assessment, what we're doing here, and the next step, which is real action, right? And so specifically, you know, the vision of that's been developed here can be considered and incorporated into a vision developed for the strategic plan, and the needs assessment tenets are akin to what people often call core values in a strategic planning process. The recommendation is a goal, priorities are objectives, and then the strategies and the tactics, which is where we're going to go right now, that really bring that all to life. There are 6 priorities, and they are, 3 of them are supporters of systems-level action, and that's the kind of action that requires centralized organization and some implementation supports. And there are 3 more that are best identified and developed at a community or a regional level. That's on purpose, so that you have a lot of allies, I have to say. The workforce, the family members, the people who are coming to the meetings are like, tell us what to do. And so that is energizing, has been very energizing as we go around, and will energize what you ultimately determine to do with regard to allocations. So we can take them one by one here. There are many more facilitating strategies within the document itself. And what you're seeing here is just investments and strategies that we believe will have pretty immediate noticeable impact, addressing both near-term challenges and/or the long-term development of infrastructure for a longer-term objective. And it also helps to create momentum. When we do this in the big bonus that you have is time. You have a long window here, relatively speaking, and you have control of your resources, which is enviable. So we would start 1 to 3 year, 4 to 6 year, 7 to 10 year kind of step up kind of a plan. And so what we're talking about here today is really that 1 to 3 year area. Let me start. Priority Area 1, develop structured relationships that foster community-driven health and well-being. This is a systems-level priority focusing on organization of the connectivity within the system and structuring community engagement, getting people involved. These attributes are at the heart of a public health model. This is investment in supporting the development of strong community coalitions and essential connective infrastructure to facilitate the communication. The initial strategies supported by research are, others are doing this with success and or have been identified as best or promising practice, is what I mean by supported by the research. 2 things that really stood out to us. One would be to engage adjacent healthcare settings in the SUD screening and treatment. More primary care in the schools, in ERs, in hospitals. We would have to think about what that was and what the various communities tell us. But that structural infrastructure would be a real advantage across the state. And second is to establish an integrated community-level components of an integrated data collection and reporting system. Those are not easy to do. They don't just show up overnight. It takes all of those serious people that know what they're doing with that data to say, you know what, these are the key markers that we should be looking at, and to start with those key markers, establish that little by little in each place so that they can be combined and then build from there. And so this is a nod to let's start on the community level development of what people tell us we need. I can speak louder. So priority area 2 is also a system level deal, and this is reducing stigma and expanding statewide public knowledge and engagement. And the stigma, as you have heard multiple times this morning, is really pervasive across the state, and it warrants a dedicated and comprehensive common approach. The potential influencing facilitating strategies we're calling out here would be to routinize involvement of people with lived experience in the sharing of their stories. That is empirically proven to be one of the most effective ways of getting, of personalizing and engaging. People realize this is my dentist, this is my next door neighbor, this is somebody's child, this is, and it starts to be real, and that gets people's attention. A second element would be to establish stigma reduction training for community members, particularly people with considerable public-facing responsibilities, such as first responders, educators, retail and community organizations such as libraries, etc. Keep going fast here, so there's a little time for question. The next three, priorities 3, 4, and 5, are all targeting objectives that we feel are best informed at a community level. And that is addressing that extreme variation that we're seeing in terms of what people need in different geographic parts of the state. The objective here is obvious. We want to prevent, priority 3, did I just read that? Okay. Prioritize prevention of drug use and drug-related overdoses and deaths. And so that is obvious. We want to prevent substance use and adverse outcomes, and it's oriented locally because of the wide variation of incidents and resources from community to community. We've noted here the inclusion of harm reduction efforts. Silke just told you how important those are, and we're including them as a tertiary prevention strategy. Recommended initial steps here would be to implement prevention services at 3 different levels. A direct prevention programming, those are there's a lot of that out there, and there are some that are really specifically evidence-based kinds of approaches. Those are called out in the report itself. Family-centered care, helping families to have healthy relationships and live in healthy environments, and then the development of champions throughout your community. A second recommended strategy is to further systemize the distribution of naloxone and drug test strips. Silke's exactly right. There are new drugs coming. They are resistant to the naloxone, but this has been phenomenally successful in our state, and has a ways to go. So continuing that really will go a very long way to keeping people safe. In priority area 4, we're talking about expanding consistent statewide access to high-quality substance use services. This is treatment. Okay, and the objective here is to provide consistent and effective treatment, particularly developing flexible and lower-cost treatment options, such as intensive outpatient programs and partial hospital programs, which are really pretty rare across the state. Addressing, again, geographic variability of need, it's a way to reach people earlier, particularly in those areas that don't have highly intensive treatment nearby. Recommended initial strategies here are to establish consistent statewide use of medical detox and MOUD. These interventions are proven to save lives and also proven to support long-term recovery. Second would be to provide pertinent local level professional development programs in support of a confident and well-supported workforce. That is a group that is really a kind of a bright light because they're starting to feel recognized. They are talking out loud about what they do. They are passionate about what they do, and you know, they are a bright light and a source of energy for all of these efforts. And then, Zilke just talked about this, engaging the pharmacies. They're located in all but 2 counties and rural hospitals to expand treatment and recovery services. 2 to go here. Priority number 5 is to normalize continuous care models that sustain progress beyond initial treatment. The objective here is to sustain treatment gains and to strengthen social connectivity. This is the importance that Zilke was talking about in terms of just recognizing the ongoing need for support and attention that substance use requires. So we are recommending facilitating strategies that address the sudden unfamiliarity and fear that people report when they transition from the structure, like of an inpatient setting, to the predictability, the structure and the predictability of the inpatient setting out back into the community. Those are really compelling conversations where people were saying, oh my gosh, you know, I want things fast, 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 but I also was scared to death. Everything was new. I didn't want to make the wrong move. So that level of support at that time and in the connectivity between key transitions is essential. We would expect and recommend to expand housing and transportation programs. Those are the two most basic needs that people say they needed the most. And by far, the two most critical factors to sustaining health mentioned over and over across the state. A second would be to provide practical supports for individuals' daily challenges and skill development. And I'm talking really practical skills, things like how do I cook a healthy meal? How do I get ready for an interview? What do I wear to the interview? You know, a lot of really basic supports that then help people to feel confident and help people to have a better experience as they're navigating. And then third would be to engage community service providers to work together to map care linkage needs and bridge connection gaps within their community. Like, let's assess what is happening and how we can start the conversation about how we can work more closely together to make transitions go a little more smoothly. And back to the last priority area here, and we're back to systems level priorities. So priority area 6 is to ensure long-term programmatic and financial stability. The objective is to proactively include sustainability factors in community planning. This is addressing concerns like the chronically short-term nature of substance use funding, particularly in the areas of prevention and harm reduction and the sustaining efforts required for recovery. A recommended starting point for facilitating strategies here includes developing common collaboration strategies throughout the state, meaning to create a consistent foundational mastery, really, of proven collaboration strategies. It's easy to say those words like you should just collaborate in your community. What does that mean? Who needs to be at the table? Who needs to bring what? How do we mobilize that from talk to action? And so meaningful collaboration development would be a good focus, good area of focus. A second is to establish the overlapping learning collaboratives. This is people who are working on their projects, working in their communities, being able to come together, and it really is a way to seek and foster shared ownership, both within a community, but from community to community across the state. And it is also a really simple way to start to get some widespread engagement of community members who may have not participated or may be curious now that they're starting to hear more. And finally, then, supporting recovery-friendly work environments, and there are many ways to do that as well. So I want to just close here and take us back to this journey, okay? We've talked about this from the perspective of an individual, but we'd also like to consider these same dynamics from the perspective of our communities, right? How do we bring people together and keep them together, particularly during these times when predictability of so many essential day-to-day structures are shifting or being eliminated? Throughout this process, the intensity of the energy and the creativity, the empathy, and the active engagement of the public was truly exceptional. You definitely won't be alone, as I mentioned, as you decide how to best allocate resources. The people power is here to help. And while it is often human nature to look inward or blame in times that are fearful or changing and uncertain, you can be a catalyst, you, the KFA board, and this whole structure within the ecosystem, a catalyst for keeping us focused, a catalyst for bringing communities together, and really are in a unique position to do that. It's legacy worthy, truly. So we thank you again for our remarkable opportunity to serve you in this way. We are excited for you to see the full report, and that will be provided on or before April 30th, along with the interactive dashboard tools that Zilka was talking about, and a myriad of data. Those appendices are deep and excellent reference materials. So I thank you very much for allowing us to talk with you today.
Thank you for the presentation. Again, I apologize for the delayed start, but that was out of our control. But I would propose for the board, I know that some of you or all of you have some questions, is that we would look for a time to get back together here in a couple weeks. I'll work with staff if we could do Q&A before we get the rest of the report, or we might do just something before then, get together for 30 to 60 minutes via WebEx in a couple weeks. So I'm going to go with that. In the interest of time, again, we got started late because of the legislature, so we'll blame them for something else, I guess. So thank you to Janine and Zilka for your presentation, and we look forward to getting into, I guess, a call for action would be a good way to look at what we'll be getting next with the full report. So if there's by not giving anybody pause on coming back in a couple weeks.
Mr. Chair, this is Sandra. Are we going to try to schedule that now so we get it on our calendars?
Yeah, I'll work with, we'll send something out. I'll work with Connie. I'm thinking just out loud here, just if we look at 2 weeks, today's the 11th, so perhaps the 25th on that Friday in 2 weeks. I don't have my calendar in front of me, but we'll send out several options and get that, try to get that worked out by this coming Monday if we can.
Mr. Chair, this is Chris. Just one thing to remind on COMA purposes. It might take us quite a few days, I could imagine, to try to get a date scheduled. So if it takes us more than a week to get a date scheduled, we probably actually need to push it off to 3 weeks from today, just because we want to make certain we're providing sufficient time for the public to be aware of the meeting and set up a physical location for the meeting to actually occur as well.
Well, we will look at all the logistic challenges and then send out some potential dates on this coming Monday. Well, with that, I will adjourn the meeting. Thanks to everybody for taking time today, and look forward to continuing our conversations. Have a wonderful weekend.
You too.